Welcome to AETCM, the Emergency Medicine Channel. Service.
Yes.
A 32-year-old male presented to ER with complaints of acute onset of headache of few hours duration, about 6 hours. On initial 10-second assessment, patient conscious, oriented, obeying commands, airway patent, breathing, respiratory rate is 18 per minute, saturation 97% in room air, circulation BP 120/70 mm mercury, pulse rate is 86 per minute, all peripheral pulses equally palpable, disability GCS 15/15, bilateral pupil equally reacting to light, exposure, temperature 98.6 degree Fahrenheit, GRBS is 125 mg per deciliter. Pain score, it was 6/10, so we had given injection PCM 1 gram IV stat. Adjuncts to primary survey, again on reassessment of the patient, pain score was only 5/10, so we have also given injection tramadol 1 ampule IV stat and injection ondansetron 4 mg IV stat. Ample history. A 32-year-old male presented to ER with complaints of...
When you're giving tramadol, what are the adverse effects of tramadol?
Vomiting.
Vomiting is the commonest problem. Then other than that?
Seizures.
Seizure, it has got high threshold for seizure and arrhythmias. Okay, so 3 important things. That's why we should always monitor the patient and give tramadol. Okay, first of all, you have to give an antiemetic that you already given, but you have to also look for seizure. Okay, tramadol withdrawal can produce seizures. There are a lot of abuse for tramadol. Many persons, they take tramadol as a drug for recreation. Can you get tramadol withdrawal seizures? That is also possible. Some patients you can see they have seizures only because they have stopped tramadol when they come to hospital. They might have maybe taking outside. We have to be very careful. Tramadol overdose abuse can suddenly produce seizure because they are withdrawing the drug. Both are possible.
It was acute onset headache since few hours. It was unilateral, that is right-sided, throbbing type. There were also complaints of nausea and vomiting. Vomiting was non-projectile. Pain slightly decreased after each vomiting. Light aggravates the headache, so we switched off the lights, so he had a slight relief.
Okay.
He had history of lack of sleep due to traveling. No history of fever, altered mental status, blurring of vision, deviation of angle of mouth, weakness, seizures, trauma history.
Why you are asking all this history?
So red flags of the headache to know whether we should take CT brain.
That is, answer is one is you are asking for aura. Okay. Second thing is you are asking for any neurological finding associated with migraine headache. Okay. Normally neurological problems are not seen in migraine. Only headache is there. If there is neurological problem, that is one of the indication for MRI or whatever it is, imaging.
No changes of headache with lifting, bending or cuffing. Patient gives history of similar episodes in the past and was on medication but not taking since last 1 week. No history of any allergies. Last meal at 1 p.m. General examination, no pallor, icterus cyanosis, clubbing, lymphadenopathy and edema. On CNS examination, GCS is 15/15, E4, V5, M6. Pupil bilaterally equal, reacting to light. Higher mental functions normal, cranial nerves are normal, reflexes are preserved, power 5/5 on all limbs. No signs of
Which all cranial nerve you want to specifically examine? Third nerve is most important. Then any other nerve?
Facial nerves.
Facial nerve, normally it will not produce migraine-like symptoms. Any other nerve will produce migraine-like symptoms, so unilateral headache, numbness, trigeminal, fifth cranial nerve. Third and fifth cranial nerve definitely you have to examine properly. Trigeminal neuralgia is one of the differential diagnoses for all type of facial pain.
No signs of meningeal irritation. Other systems, no abnormalities detected. Diagnosis, common migraine.
Okay. What is the difference between classical migraine and common migraine?
Common migraine, there will be no aura. Classical migraine, there will be aura.
Okay. So how do you manage this case first? This patient has come with severe headache to emergency room. How do you manage the case and what other investigation you require, or if at all no other investigation, you can tell that also.
First, the pain management.
You are given paracetamol.
Paracetamol.
Okay.
And if not controlling with that, mild opioids can be given.
Okay.
Then we will check, or triptans can be checked.
What triptan?
Um,
What are the triptans available?
sumatriptan,
Okay.
risatriptan.
Okay.
Risatriptan can be sublingually
Sublingual.
can be
Okay.
tried.
Okay.
Then high dose opioids.
Opioids is like your tramadol or morphine. Okay. So this patient, what happened after giving your paracetamol and tramadol? What happened to the patient?
Actually, pain reduced, relieved after this tramadol.
Tramadol. Okay. So any past history of similar complaint for this patient?
He was on sumatriptan, but he
Okay.
was stopped since 1 week.
Okay. Now we come back with a severe headache.
headache.
Okay. Now the question is, normally in migraine, you all know that migraine, unilateral headache, severe vomiting, all these things can happen. So once the patient come to emergency room, we have to treat the pain. That is the first thing. Second thing is whether to take a MRI or CT. That is very important. So what are the red flags in headache? When will you ask for a imaging in headache?
More than 50-year-old male with hypertension. If he's coming with headache, we should take CT.
So what is there in your mind when you are asked sending for CT?
Any SH or IC bleed.
Okay, high BP with SH or whatever it is. Okay.
And thunderclap headache.
So severe headache, first
Most
time,
worsening.
the maximum severity on that episode. Also, you can ask for MRI or CT. Then
Any neurological deficits.
associated neurological deficit you have to take. Then
Raise the ICT signs like pupillary reflex.
okay, abnormal pupillary reflex or abnormal pupils, asymmetrical pupil you have to take. This patient is already having headache. Okay, already having migrainous headache for past many years. Now he has come with another episode of headache. And how do you assess whether you require a CT or MRI?
Change in pattern. Or
Change in
severity of
pattern.
the headache.
Either the side is changing. Normally, most of the migraines will occur on the one side, and if for a long time it is same pattern, suddenly it's changing in the side of the headache, or the severity suddenly increased than the previous episode, then you have to take. Okay. What are the associated neurological findings seen along with migraine, other than without any actual deficit? What are the common neurological deficits seen with migraine?
Weakness, hemiplegic migraine like.
Hemiplegic migraine. The commonest problem is always visual loss. Sudden visual loss in any patient during migraine episode is a commonest finding, neurological finding in patients with migraine. Second thing is hemiplegic migraine. One-sided weakness or one arm weakness is very, very common in migraine. Okay, so that many patients actually experience. Okay, what are the auras in migraine?
Like most common is visual. Then
Rotters.
auditory or olfactory.
Okay. Any abnormal perception of any like eye, ear, whatever it is migraine aura. Okay. So you have discussed about MRI, requirement of MRI. So what all findings you can get other than migraine patients in MRI? Associated features. Can you get any findings? Normally it is not very common, but patients who is having high BP with transient visual loss, there is something called as press syndrome. So that sometimes happen. It can mimic like migraine. Okay. Now, what is the role of adjuvant therapy in migraine? Adjuvant therapy, now you have given risatriptan, sublingual, and pain relievers you have given. Adjuvant therapies, along with that, you can try all these things, but they are not definitely going to help the patient without the original treatment.
Can be oxygen inhalation.
Oxygen, high flow oxygen can be given. What is the action of oxygen on blood vessels?
Vasoconstriction.
Vasoconstriction. What is the problem in migraine?
Vasodilatation.
Vasodilatation. So oxygen can be started then.
Naproxen.
Naproxen is NSAID, no?
Along with sumatriptan.
That is painkiller. You have already given paracetamol or any other NSAID, you can give. Naproxen is also an NSAID. Then role of magnesium? Magnesium sulfate can be given, but it is only an adjunct therapy. Okay. Now, how do you suppose this patient is admitted here? When will you decide to discharge the patient? So you know when to take an MRI. That is most important. Unnecessarily taking MRI in migraine is not good. Okay, only if you have a red flag like this, you can go for MRI. Now, how do you discharge this patient? When will you discharge the patient? When will you discharge the patient? So, this patient is admitted in emergency room, you have to discharge.
And the
No need to admit
is,
all patients with migraine.
and pain is relieved or no recurrent episode.
So, what you will advise? When you are discharging, you have to give some medication. What you will advise? It is called as migraine prophylaxis. So, if the episodes are very frequent, if it is affecting his daily life, then you have to give migraine prophylaxis. What are the drugs you can prescribe from emergency room?
We can give propranolol.
Propranolol. What is the dose of propranolol? Propranolol, what is the dose? You give in other conditions also, no? 40 mg. 40 milligram sustained release tablets are available that can be given BD doses. Okay. What are the contraindications for propranolol?
Asthma, bronchial asthma.
Okay. Bronchial asthma.
And
Palpitation tremor is not a contraindication. No? It's given for that. Propranolol is given for palpitation and tremors. Bradycardia. Okay. Two important contraindication. One is like you told asthma and one is like bradycardia. So propranolol can be given. Any other drug can be given.
topiramate.
Topiramate can be given. Then flunarizine can be given. If the any tricyclic antidepressants also can be given. Okay. So here, what happened to the patient afterwards?
Patient was better on after injection tramadol. So we observed here for any recurrent attacks. And,
Okay. Now, what are the triggers for migraine? So you have to counsel the patient, counsel to avoid triggers. What are the triggers of migraine?
Sunlight.
Sunlight. Commonest is sunlight. Then
Food intake.
Skipping of food can produce headache.
Sleep deprivation.
Sleep deprivation can produce caffeine, chocolate, some smells, spray. All these things can produce migraine. What is encephalorrheic migraine?
There will be no headache, but only aura will be present.
Aura or neurological findings. Sometimes patient will have sudden visual loss. That may be the only finding in that type of patients. Okay. So basically, when a patient comes with headache in emergency room, you have to make a diagnosis whether it is migraine or not. That is the first thing. So other than migraine, there are a lot of other headaches that we'll discuss now. Second thing is whether to take an CT or MRI. That is very, very important because already in a migraine patient, they might have taken an MRI in the past. Unnecessarily taking MRI in that patient is not correct. Okay. Now, what are the other reasons for headache? So heavy headache, patient can come to emergency room. The same patient who is already having migraine itself can come with headache. What are the other reasons for migraine? Their differential diagnosis.
Cluster headaches.
What is cluster headache? You should know the clinical feature, no? What is cluster headache? So sudden onset of headache and with along with conjunctival suffusion, fullness of ear, eye, all these things can be there. Cluster headache, very, very, very rarely it can occur. Not like migraine. Frequency will be very rare. Once or twice in a year they may get it. Then, what is tension headache? What is that? Band like all over the head you can get tension like. It's not throbbing type of headache. Then hypertension, high BP, can it produce headache? Okay, so that also can produce a headache. Then intracranial hemorrhages, that also can produce headache. Then trigeminal neuralgia can produce headache. What is a typical feature of trigeminal neuralgia? Only one side of face fully is involved. There are some lesions also can be there on the ear area. What is that condition called as? What is that? That is ophthalmicus is only eye. If the trigeminal nerve and inside the ear, if you are seeing lesions, what is? Ramsay-Hunt syndrome. Ramsay-Hunt syndrome can, that is all rare conditions, but it can also produce this one. So migraine can have a lot of differential diagnosis, and early morning headache is another type of headache. Early morning headache. Which all conditions you get early morning headache? Migraine normally migraine develops mostly in the afternoon. Most of the patients. Some patients rarely can get early morning headache. What are the conditions you get early morning headache? Sinusitis. Most common condition is sinusitis. Other conditions? Other than that? Hypertension also sometimes present with early morning headache, because most of the patients take tablets in the morning around 8 o'clock, 10 o'clock. By next day early morning, the effect might have waned off. So the patient develops headache in the early morning. That is one of the common cause, but the commonest cause for early morning headache is sinusitis. If the patient is having, along with the headache, if the patient is having seizure, what will you suspect? Seizure. Severe headache, after that patient develops seizure. What are the possibilities?
ICT,
Due to what?
IC bleed.
IC bleed. IC bleed is the most common condition. Sometimes tumor. Tumor also can produce seizure with acute headache. In tumor, what happens? Suddenly, why should the patient develop headache?
Any bleeding?
Bleeding in the tumor. Okay. Bleeding to the tumor, which is already existing, patient can have severe headache with seizures. So these are the possibilities. Basically, when somebody come with migraine, we already know that it is migraine. There is no need of much investigation. Just switch off the light, give paracetamol and wait. If patient is not improving, then you give tramadol or whatever it is. Can we give morphine in migraine?
Yeah.
Can you give? Yes or no? Yes or no?
Yes.
Yes. You can give morphine, but there are a lot of studies which have proven that once you give morphine, every time patient will ask for morphine. So that will become a habit. Patient will come for only for morphine. There are a lot of patients here also. Once or twice you are given morphine, then they come for only for morphine injection. So in migraine, morphine injections are not well indicated. They are actually it is not contraindicated. You can definitely give morphine, but it will produce a habitual formation. So try to avoid this type of drugs. Even tramadol also sometimes they develop habit. So better to give a paracetamol, or like you told, naproxen, caffeine, all these things can be given. That avoids the habitual formation. Okay. Anything else you want to add? You have written so many things. You want to add, you can add. I think everything is told already. Huh? Okay. Thank you.